Okay, so hi everyone, and thanks ever so much for joining us for this webinar tonight. For the benefit of timings, because we're doing a 1 hour webinar tonight, and we've got lots to pack in. So I'm just going to go through these first little bits so that we can get started at 7:05, and people can just join us as I go through these bits. So this is a British Pain Society webinar hosted by the Primary and Community Care Specialist Interest Group. I'm Dr. Graham Dunthorne, and I chair the Primary and Community Care SIG. So the British Pain Society are the oldest and the largest UK multidisciplinary team organisation. We're a community of professionals treating and researching pain collaboratively with people who are living with pain. We hope to champion a person-centred approach to pain care, advocate for better pain care with policymakers, and advance education and training, guidelines and resources. We're also trying to promote research to improve the understanding and the treatment of pain. Just drawing your attention to the next annual scientific meeting, which is being held at the Harrogate Convention Centre between the 21st and the 23rd of April 2026. Okay, so a little bit of housekeeping for you. All questions into the Q&A, please. We'll be doing a Q&A at the end, but for the benefit of keeping things on time, we'll not be doing questions as we go along. We are recording the webinar and it will be on the YouTube channel afterwards. And please do complete the evaluation form to claim your certificate of attendance, and you'll receive that link by email. So tonight's webinar is going to look at pain and Long-Covid syndrome, and we're going to pair that with mindfulness-based lifestyle medicine for chronic conditions. So we're really delighted to have two speakers tonight. Our first speaker will be Dr. Noffel Muller, who will be speaking about pain and Long-Covid syndrome. Dr. Noffel Muller is a consultant pain physician and clinical lead for an integrated pain service at Bedfordshire Hospitals NHS Trust. He has a specialist interest in medical education. He's a senior consultant appraiser and has served as a member of the Drugs and Therapeutic Committee, and also of the Clinical Guidelines Committee in his trust, and was a regional advisor in pain medicine in the East of England and Cambridge Deanery. He's the Education Subcommittee member at the Faculty of Pain Medicine and at the Royal College of Anaesthesia. So that's our first speaker. Our second speaker, who will be covering the mindfulness-based lifestyle medicine for chronic conditions, is Colette Power. Colette is a meditation teacher and mindfulness trainer. She's a supervisor and mentor. She is a certified mindful self-compassion teacher and leads retreats in the UK and in Europe. She trained at Bangor University and is a senior breathworks trainer. She has delivered mindfulness pain management programs since 2012. So hopefully I got all that about right. So just a little bit about timings. So the first speaker will be starting about now for 20 minutes. We'll then have our second speaker for 20 minutes, and that will leave us with 15 minutes for Q&A. And Satish Singh, who is the Secretary of the Primary and Community Care SIG, will be leading the Q&A for us tonight. Right, fantastic. So I shall stop sharing and hand over to Dr. Noffel Muller. Thank you very much.
Great. Thank you very much, Graham, and the team at the BPS, Satish, and all the rest of you. First of all, may I just ask you to confirm that I can be heard and the slides can be seen?
Yes, all good.
Yeah.
Right, thank you. Yeah, so you've already gone through my introduction, so I'll try and start the program. Thank you once again for the opportunity. I don't have any conflict of interest today. The presentation may have off-label used medications and other treatments. It's a very wide topic, so whatever resources I've touched upon or gone through for this talk, they are not exhaustive. The learners and participants are requested to refer to other resources for more elaborative information. I haven't been in receipt of any speak honorarium, and I have taken sources from material from various sources, including any AVs. So I felt that to understand the long COVID syndrome associated chronic pain, it was important to first demystify the term nausoplastic pain, which is a new nomenclature for a different type of pain. So conventionally, we were used to understanding what is nociceptive pain, the kind that we see after injury or surgery or inflammation, which is limited sort of by its brevity. It is conventionally defined as that pain which does not occur beyond the period of healing. So there's a clear evidence of actual or threatened tissue. Which is sort of the definition by the International Association for Study of Pain. And then we have neuropathic pain, which is a very pedantic definition, which is a pain that arises as a result of lesion or dysfunction of the somatosensory nervous system. Now, nausoplastic pain has features of either both, or you could consider it as an entity by itself. And to understand long COVID syndrome related pain, it's important for us to understand what nausoplastic pain is. Long COVID syndrome, as a definition, is a condition that occurs 3 months after the initial SARS-CoV infection, which is COVID-19, with at least a single persisting symptom. It could be anything, shortness of breath or chest pain, which will stay with the patient for at least 12 weeks. In terms of its prevalence, 6 to 7% of adults can suffer from it after having undergone COVID, diagnosed COVID with the test, and gratifyingly a small number of children, and not as high as adults, but they do get a long COVID syndrome and related pain as well. There's less incidence after vaccination. And just to get an idea, because the patient cohort is likely to be the ones where nausoplastic pain has been identified in other conditions, for example, fibromyalgia, irritable bowel syndrome, TN joint syndrome, long COVID pain syndrome is something along those lines. So those of you who have read about the Cartesian model of pain, the French physiologist René Descartes was talking about the dichotomy of the mind and the body, where the physical or the biological pain was said to be arising from the body, and it was completely uncoupled from something which was not a physical pain. Let's call it psychological pain. This duality actually needs to be challenged, and nausoplastic pain and consequently the understanding of long COVID syndrome related pain helps understand this, because patients do feel stigmatized. They get this impression, their perception is that because their pain couldn't be explained, they can get stigmatized, and they perceive that the clinician is telling them that the pain is just in their head. And we have to understand that pain is different from pain behaviors, and hence human experiences, they're error prone, and they're real, and they actually shape an individual. And that's how we have the concepts of phenotype or epigenetics, where patients' disposition of the phenotype is not just a biological in origin. Yeah. So we need to understand that, or rather break away from the shackles of that very old paradigm of disconnecting physical and mental pain to be able to understand this type of pain. This is a bit pedantic, the slide, but it helps us understand and discern the three types of pain. It's a bit of a repetition of what I said, which is nociceptive pain linked to actual injury or inflammation. And there's evidence that there is involvement of both peripheral and central nervous system. And usually this is the kind that we see as a post-traumatic or from a disease process like arthritis or post-surgical. As I said, it's got to do with healing. Neuropathic, once again, there's a recognizable disease, for example, diabetes, which affects the somatosensory nervous system. And if you look at the nausoplastic pain, it's not really related to nociceptors, which is the receptors that we find in the periphery. It's the classic example would be something like fibromyalgia. The central nervous system dysregulation is very much involved. And although the only way these conditions are sort of presumptively diagnosed is by tests for excluding other organic causes, and that needs to be understood. As you all know that to understand any classification, we have to check the validity, the reliability, and the ability to generalize it to population studies. Moving on. So this is just like an algorithm. If patient presented with what we call chronic pain, it's a temporal definition of pain beyond 3 months, but let's call it anything which is beyond the period of healing. So this gives a nice algorithmic approach to whether the pain is regionally distributed, is it nociceptive in nature, whether there's elements of neuropathic pain. And at every stage, we need to exclude this. Some quantitative sensory testing like evoke hypersensitivity may be tested, but usually we won't be able to do that in clinical settings. That's more for research and analytical areas. And possibility of presence of at least a comorbidity may help us exclude nociplastic pain from either a neuropathic or a inflammatory nociceptive pain. This is just what we've been understanding about the sensory and the pain pathway. I always perceive it like a computer where you have an input, which is what we type, central processing unit, which is the motherboard, and the output, which is the stimulus, which we see. So we have these nociceptors, which are in the periphery. They get stimulated by tissue injury. There's like this inflammatory sensitizing soup with all these compounds like substance P, serotonin, acetylcholine, and then they travel in the lateral spinal thalamic tract, which decussates and enters the brain. And the more sort of cerebral aspect of it, which is in the frontal cortex, which is a higher function, that's the one where patients respond to the stimulus. But if you look at the diffuse descending pathways, which are in the deeper structures of the brain like thalamus and putamen and basal ganglia, they are the sort of emotional aversive aspects of pain, a bit more pain behavior rather than the organicity of pain, like quantification with the score. It's the emotional aversive behavior which is responsible for consequently nociplastic pain. And this is just a little bit of science about what happens at various levels. And I felt this diagram was important because it also shows us drug targets. So in terms of long COVID chronic pain, obviously it's related to the very tragic epidemic, rather the pandemic in 2019, which originated in Wuhan. And then the entire world was affected by it, 250 million people. It ran a very protracted course with unfortunate amount of disability and fatalities. It was noted that at least 50% of the survivors went on to experience long COVID or some sort of a sequel from this disease. And although our focus is going to be pain, there's a lot of disability which is also non-pain related. And it's fascinating to see that it's almost like on a continuum, on a spectrum, where they start resembling central sensitization syndromes like chronic fatigue syndrome or widespread pain syndrome or postural orthostatic tachycardia syndrome. And those of you who have worked in the clinical setting like this would have been able to recognize it. I got 3 real-life examples from my clinic in Luton and Dunstable, where I do the chronic pain clinics. I had a young patient who gave history of COVID a year ago. Initially, her illness appeared a little bit like flu-like, but she said that she never fully recovered. She had consistent exhaustion, widespread pain, malaise, and she used descriptors like crippling. She had to get laid off from her job, and her pain kept getting worse despite the OTC analgesics. She confirmed that she had not received any COVID vaccines. Then I had something which is like a bog standard in chronic pain clinic, which is low back pain, the bread and butter type. Pre-existing low back pain, very well controlled, and the patient presented with exacerbated magnified symptoms of axial low back pain and no response to that pain. This patient had received all the doses of the COVID vaccine. And then I had an unfortunate college-going student who had COVID negativity, but suffered from all symptoms a couple of years ago, and then presented with this multi-quadrant pain, and it had all the features of a widespread pain index and symptom severity score of fibromyalgia. The patient was performing, there was some scholastic backwardness, and they didn't perform well, and they were greatly benefited by an ACT acceptance and commitment therapy type approach in psychology, and low dose amitriptyline. They did confirm that they had not received any vaccination. So in terms of the definitions and taxonomy, various names have come up, as you can see from the slide. But currently, the one which we are using is Long-Covid syndrome or Long-Covid syndrome related pain. So within the UK, there was a research group that clubbed it into two groups. There were some that were acute, sort of subacute to acute, but relentless symptoms of COVID-19, and they gave narrated the experience of the syndrome almost 4 to 12 weeks after an acute infection of COVID. And then there was one which is sort of running an indolent course, a little bit chronic, following having suffered for 12 weeks or more after the acute onset. So there was this temporal difference. And then some patients may not have had any COVID symptoms during the time they actually got the infection, but they just tested positive. And a lot of them were healthcare professionals, including myself. Didn't have symptoms, but organizationally were undergoing tests and were testing positive. And then there was some who had got hospitalized as well. So you see, like, there's this gamut of patient cohort. In terms of the pathobiology of the virus itself, so it was as we know, it was very neuroinvasive. It rapidly attacked the central nervous system or peripheral nervous system, and it continued to replicate and involve cranial nerves. Some of you who may have suffered or cared for the patient would have seen that olfactory dysfunction and parosmias were almost like heralding the onset of the disease. And some patients had gustatory problems. Some patients presented with what looked like an innocuous belly ache, but turned out to be a florid COVID infection with ventilation and the works. The spread could happen either through a blood-brain barrier or blood-CSF barrier. Clinical presentation of long COVID, it's a myriad of symptoms. So the classic one I've got is, I have got brain fog. And you think, I'm not paraphrasing, the patient enters the clinic, I have got brain fog. And you've heard this repeatedly from patients of widespread pain syndrome. But some were getting extreme symptoms like a stroke because of the whole vascular effects, depending on whether they were having pulmonary symptoms or psychiatric, where they were presenting like PTSD from their own suffering, or that from prolonged hospitalization leading to social isolation. I did see some patients with cutaneous manifestations, but I didn't consider myself as an expert to say that this was a COVID manifestation. But yes, there were sporadic cases where they came with pain, but they came with some sort of an urticarial type rash. And of course, there were some that got myocarditis. The one that I've highlighted here is the one that we'll be encountering in our practice, which is the joint pains, radicular pain. Either it could be mononeuritis, or some patients actually had bilateral symptoms. There was no laterality of symptoms. And of course, some that had the vascular abnormalities, and they presented with ischemic symptoms in the lower limbs as well. So there were some risk factors for this who went on to develop this type of pain. So the patients who were admitted during the pandemic, and they had a lot of pain from either chest-related morbidity and consequently the treatment, for example, thoracostomies, chest drains. They were the ones that presented with pain in the rib cage. There were patients who were morbidly obese or had other comorbidities. Elderly patients was another group. The ones that were in intensive care because of prolonged ventilation and neuromuscular blockade, as well as SIRS and sepsis, they were the ones that also presented with long COVID type chronic pain. And of course, the one that I just discussed, the one which presented with the CNS symptoms. There were some that had pre-existing mental health burden, and their symptoms got exacerbated. They had PTSD from suffering itself or that of their near and dear ones. There were healthcare professions who also presented as patients. Patients that had because of the lack of understanding, there were lack of strategic pathways how to approach patients. And often in a pandemic like this, which obviously for our generation, and I hope for many generations to come, they don't have to undergo this and endure this. There wasn't established pathways. So there was a burden on the services, and people didn't know how to care in the immediate aftermath because the entire focus was on the acute management. I don't know if any of you all came across people calling fibromyalgia as the new COVID. And if you see, all the patients in this sketch I've got are the ones which are the central sensitization syndrome, like chronic widespread pain syndrome, myalgic encephalitis, chronic fatigue syndrome, that type of sick building syndrome, or patients who have silicone implants in the breast, those kind of patients, patients who have headache symptoms, tension headaches, painful bladder syndrome, as well as secondary type of mechanical low back pain. So this is a cohort of patients and the end joint of nausea-plastic pain who were presenting as patients of COVID. So this one I've got from an American source, where if the patient has presented with chronic neuropathic pain and gave history of either COVID infection or vaccination, there's a nice algorithm. If you see, we are going up the step ladder, but it doesn't mimic like the one which we are used to seeing in the world of pain medicine, which is the WHO ladder. In here, you can see that on step 1, you could still have voltage-gated calcium channel blockers like the gabapentinoids, or tricyclic antidepressants, or sodium channel blockers like lidocaine and carbamazepine. And then you can use reserve drugs, for example, SSRIs and SNRIs. Occasionally, with the help of my neurology colleagues, I had to incorporate muscle relaxants like metocarbamol, baclofen, clonidine. Because this is an American slide, they have put medical cannabis, but that's not part of my practice. But yes, for me, the step 3 to 3, 3A to 3B, you can call it, is intravenous lidocaine. I do give them in the recovery room around 5 milligram per hour for 5 milligram per kilo for a couple of hours. And I have seen benefit in patients of this type of pain. Here they have written for severe exacerbation, you can use opioids, including methadone, something I refrain from. But if patients are already on it and are using modified release, then I feel duty bound to say that at best I could ask the GP to convert it to something like a transdermal. If a patient gave history of chronic hospitalization and pain that was associated with rehabilitative care, then they needed a more robust rehabilitation package. If they had exacerbation of their pre-existing chronic pain, then they needed to go to a pain MDT. I work in a trust where we get judiciously job plan actually to do weekly MDTs. So I can see consolation in the fact that I can triage these patients into that MDT, and then I can, I'm involved in making a nice package for them if we diagnose them. Although there are no tests to diagnose apart from the history of having suffered from COVID. Most of the treatment is focused on education, not just of the patient, but also of our health profession colleagues. This is just sort of a repetition of what I said, where if a patient had prolonged hospitalization, they were considered for an MDT type approach. And basically the anti-neuropathic pain guideline of NICE, it is quite, it's not very regimental, but it's very, very specific, asking us to try tricyclic antidepressants, give them at least 6 to 8 weeks of therapeutic trial. And if they don't get benefit or get side effects, then move on to voltage-gated calcium channel blockers, and then SSRIs and SNRIs like venlafaxine or duloxetine. But at every stage, I feel that having a therapeutic, pharmacotherapeutic approach alone wasn't good enough, and a more comprehensive approach involving psychology, physiotherapy, and we also have occupational therapists who participate in our MDT. I found that invaluable. There has been a lot of talk of non-therapeutic approach for long COVID type pain by electrical stimulation therapy. So the two that are currently being trialed are cranial stimulation and microcurrent electrical therapy. So this just involves giving a small burst of biphasic stimulation, and they do through temporal electrodes. And the session can last anywhere between half to an hour. So the postulated mechanism for this is that it results in deactivating those regions that are consistent with hyperactivity. Obviously, this kind of treatment is releasing inhibitory neurotransmitters like glycine and GABA, and they sort of antagonize the ones which cause stimulation, for example, aspartate. It also is known to work through alpha wave activity and decreasing the delta and beta, which is the one that results in sleep disorders from nocturnal pain. There's some evidence to show that it releases the beta endorphin, the happy neurotransmitters, as well as melatonin, and patients do feel quite rejuvenated if they get this treatment. And of course, there are serum and blood levels of cortisol in the brain is known to come down through the suppression of the neurohumoral axis. And of course, increase in ATP. So I have worked with some general practitioners, but outside the NHS setting, where they give NADP infusions to patients of long COVID, and the patients have been benefited by it. Only recently, a fine gentleman from the north attended our MDT because he works for vagus nerve stimulation. And although he had come to us with use in vascular surgery, we tried to indulge him in using it for pain medicine. And I was rather pleasantly sort of surprised that, it had some use. And then I did some research in the literature world, and in the States, they are trying auricular vagus nerve stimulation for helping patients of long-COVID syndrome, and actually even other types of nausoplastic pain. Vagus nerve stimulation does reduce inflammation and also glia, like astrocytes and oligodendrocytes and supportive structures in the brain, which are known as involved in modulation of pain. It is also known to increase norepinephrine and enhance cholinergic activity, which is known to, obviously, it's parasympathetic in nature, so it combats the flight and fight response, and also increases the wind-up in the neuroplasticity in the brain by increasing concentrations of brain-derived neurotrophic factors. So our nervous system is quite malleable. It's not hardwired. It's known to alter its function in response to the stimulus. And vagus nerve it's a fascinating nerve. It intrigues me. It has this kind of various targets on which it can work within the central nervous system, including the limbic circuits, where the emotional aversive concept of pain is, and most of the long COVID pain patients are that. A lot of buzz is going around in our world about doing stellate ganglion blocks for long COVID. Again, the fundamental nature of any sympathetic block is that it will suppress the neurohumoral suppression. And stellate ganglion block is extremely easy for people like us who are trained in it. And although I haven't tried yet, I have got a patient on the waiting list who is scheduled for this procedure, but they also consequently have developed CRPS in their hand from not related to COVID issue. So I can justify doing it, and I'd be quite keen to follow this patient up. For those of you all who have heard about the SHADE study, there was a placebo-controlled randomized trial where they gave vitamin D supplements, which is known to help patients with this kind of nausoplastic symptoms, especially in COVID-19. And some of you all might remember that at the time when the vaccine wasn't even in its inception phase, a lot of people, including my own family, were taking high-dose vitamin D because there were being talks about how it's got some role. And there was a trial that did conclude that vitamin D is likely to help in this kind of long-COVID-related pain. So in terms of its disability, yes, during the time COVID epidemiology was being studied, certain groups were at risk, like older people, ethnic minorities, women. And in the US, the CDC started recognizing long COVID also as a disability. There's an Equality and Long COVID-19 Act, where they say that if the patient, there must be a physical or mental impairment, and if the disability is for longer than 12 months and hampers in their day-to-day activities, they can qualify as a disabled person. There is some information on that. I've got a hyperlink over there if anybody is interested. So in terms of how to prevent COVID, I think the most fundamental nature, although there will be people who may challenge that, is actually to get vaccinated. Because it's not just preventing, or at the time did not prevent people from getting COVID-19, but it is also known to prevent development of long COVID syndrome. The UK Health HSA had done a review of long COVID studies, and they found out that the vaccines were half as likely to, patients who were vaccinated were having 50% chances of not getting long COVID symptoms if they took the vaccine on time. There was also a study that was published in the BMJ that concluded that vaccination prevents development of long COVID, apart from catching the COVID infection. Of course, if you are working in an area where, especially as we're entering the winter, it's advisable to use the PPE equipment as appropriate. This is just a COVID-19 guideline that has published a document on the management of long-term effects. I've read this document. Not a lot has been specified about chronic pain, but the other symptoms of long COVID, it's a good read, and it has been vetted by most of the important organizations. So that is something which is likely to help us as well. So long COVID syndrome, although it was 5 to 7% prevalence in adults, it is still in its nascent stage of understanding. So there's a lot of work to be done if you have to look at the future. Because the disease has been new, it's evolving. I think the fundamental thing is the education of the patient and HCP. There has to be an organizational support. So a lot of hospitals and trusts, including ours, we have dedicated well-being teams. And Anisita from my hospital is actually one of the leads on it. Patients and healthcare professionals can report. We are just romancing with the idea of a long COVID chronic pain clinic. It'll be a tall order for us to actually incorporate one, but talks have begun in our trust to have something similar, because we do have post-intensive care outreach clinics catering to sufferers of long COVID. So why not pain? Because pain is likely to be one of their symptoms. Once we recognize the patient that is at risk, they have to be signposted to the appropriate healthcare professional, i.e. a psychologist or a mindfulness expert like Colette, and allied healthcare professionals who help with occupational and vocational rehabilitation. We do have an occupational health physiotherapist who just does a clinic a week, and it's a walk-in clinic, and we encourage people who are staff members who suffer from symptoms to go and attend those. As I said, outreach clinics in high dependency and intensive care for patients that were admitted and had increased comorbidity, that could be a way of looking at it. And last but not the least, the focus group today is obviously community and community-based clinics, which Graham and I last year have talked about integrating secondary care pain clinics within the community. I think they'll be like the absolute ultimate milestone to work on in terms of managing these patients. These were the references that I used for my talk, if anybody is interested in referring to them. Just reinforcing that if you haven't got vaccinated, please do so, because we just proved that there's an increased role for that in prevention of long COVID associated chronic pain. Thank you very much. Any questions?
There are no
Thanks
questions so far. We'll take some at the end. Yeah.
No, it's okay. So I'll just say thanks very much for that, Naval. That was absolutely fantastic. We're going to do Q&As at the end. So if you are able to just hang with us, we'll just hand over to Colette to hear her presentation first. And yeah, thanks very much, Colette.
Thanks, Naval, and thanks, Graham. I'm just going to share these slides. Hope they work out. Can you see them okay?
Yes.
Yeah, okay. So as Graham said, I've worked in the mindfulness field for 15 years or so. And I trained in various interventions, MBSR, MBCT, and also in mindfulness-based pain management. I've worked in that for 15 years with a range of people, a range of injuries, conditions, and illnesses. Great, the slides are working. Okay, so just to say a little bit about the organization that I work for. It was founded in 2021, and you'll see the Mindfulness for Health book there that won the Popular Medicine Award in 2014. And it was written by Vidyamala Bhatt, who'd been working with around chronic spinal condition for 40 years plus now. So together in the organization, we've taught about 700 teachers in about 40 countries. I was in Poland earlier this year exploring teacher training for mindfulness-based pain management there, and I'll be delivering in Germany at the end of the year. We've been delivering training there for many years. So short and sweet presentation. I'm going to talk about the HEALS program. That's an acronym. I'll explain a little bit more about that as I go along. Just look at the pilot studies and a couple of feedbacks and evaluations. So just to say a little bit about the context of the HEALS course, which is the acronym, it draws upon the program, draws upon developments within the lifestyle medicine field, an evidence-based approach, aiming to support patients to manage certain chronic conditions, and recognizing the impact that daily habits have on long-term health, and also supporting change in various areas of diet, exercise, and stress management. And the goal really to support and to sustain lifestyle change. So a little bit on the history of Breathworks as well, the HEALS program. It was born out of the Breathworks community's experience of what helps to improve well-being and quality of life when living with chronic pain, fatigue, and various other illnesses. So guided by a clinical advisory board of active GPs, groups were formed from people living with pain and illness to explore what approaches and formats worked best. So from these collaborations and observations and 3 pilot studies, a 10-session program was developed, which is rolled out over 11 weeks. So the program, the HEALS program, helps participants to establish a mindful and compassion-based approach to health and well-being, and it provides lifestyle education and a template for behavioural change across a range of areas that support well-being. So there are 5 areas or 5 pillars of well-being, and in order to remember those are the basic areas: mindfulness and meditation, lifestyle education, and behavioural change. And the acronym helps us to remember those particular pillars: healthy nutrition, engaging with movement, awareness, love, positive emotion, cultivating connection, so connection with self and others. And of course, it's reminiscent of previous models, the 5 ways of well-being. I think that was rolled out in 2008. And the slogan was to connect, be active, take notice, keep learning, and give. So given that there are other models that use the 5-pillar methodology, what's special about this program? So Breathworks expertise, and the expertise of many of the trainers, is in mindfulness, meditation, and compassion-based approaches. And they cultivate a sensitivity towards what's happening physically, emotionally, and mentally. And this in turn leads to responsiveness towards our needs and towards changes in our health and lifestyles. So just to pause there and just to say a little bit about the cultivation of mindfulness or awareness. So it helps us to establish a connection between what we do, what we eat, and how we move, and what we think about, and the effect on our general health and outlook. So when we join the dots up between what we do and how we feel, we can then access a sense of agency, because we can change some of the things that we do to our benefit. But we have to be able to see what's happening first before we can see what we need to change. And we have to care for our well-being. So the practices, mindfulness and compassion-based practices, support self-care and provide methods of pain and well-being management and self-regulation. They help us to understand that we have choice and that we are capable of making changes in our life. So putting lifestyle choices center stage supports people to invest in what makes them healthier and happier, while cultivating the ability to discern what's unhealthy and unhelpful. So, in other words, what supports health and what depletes it. There may not be anything to be done about certain conditions, or, for example, in Vidyamala's case, there's no taking her pain away, but the focus shifts to managing and supporting well-being in that case. So my experience is that of doing the mindfulness-based pain management course and the HEALS program is that people know on some level what supports and what depletes them, but they don't always have the confidence or motivation to choose wisely. So loneliness eats away at motivation and purpose, and leads to other mental and physical issues as well. So ongoing contact during the course, remember it's rolled out over 11 weeks, contact in that learning environment supports people to choose wisely and to make small incremental changes that have a big impact over time. So their efforts during the program are witnessed, celebrated, and reinforced. So it enables people to keep on choosing wisely over the 2-month period and beyond. So the community factor is one of the most healing and practically supportive pillars of the program. So perhaps I'd like to emphasize another aspect of the course, which is not one of the pillars, but which I've discovered to be really valuable myself, and that's the tiny habit behavior change model. So I experienced early menopause, and some weight-bearing exercise is really useful for me. So I bought weights, I put them on the shelf, and there they stayed. I then looked at this willingness or wish to do more weight through the tiny habit model, and I used a prompt. So every time I stand up from my desk, I've got the weights in front of me. I use that as a behavioral prompt. So every time I stand up from my desk, I maybe lift a couple of weights, not many, and not for long. I don't do it every time I stand up. I just do it a couple of times a day. And there's a significant build-up over strength from this small incremental change. So participants on the HEALS course used the tiny habit model, for example, to stay hydrated, to remember to do strengthening exercises if there's been periods of immobility. One woman, for example, needed to build up muscles in the calf after a long period of immobility. She did, every time she did the dishes, she did some leg strengthening exercises, just a few, just when she did the dishes, and that speeded recovery significantly. And rather than the movement being something else she had to do that she didn't want to do, she just assimilated it into domestics, if you will. So I just want to say who the course is for very briefly as well. It's for people who live with chronic pain, illness, fatigue, those who feel overwhelmed by sometimes there's an avalanche of health advice and they don't know where to start, and they may need some extra support. For people who juggle with busy lives, maybe they've got caring responsibilities or other commitments, and it provides added support. And people struggle with motivation. We know we need to do things and then we don't do it. So it helps us to, being together in the program helps us to stay on track. So how does the program work? Well, one of the valuable things about the program is it's online. It's delivered on an online platform, and the live sessions are facilitated by skilled and trained teachers. It includes a variety of activities, meditations, breakout rooms where people can discuss specific health-related issues, where they can share their experiences, where they can be ahead. There's PowerPoint presentations, home practice in between the weeks, and there's buddy groups where people can maintain contact over the 11-week period. So those groups enable people to explore how best to incorporate the week's learning, whether it's on movement or nutrition, into their daily lives. So these are as an example of the online resources for the course. So for the first week is awareness. I'll just blow that up a bit. So you can see the sessions are live and we go through all the material. But of course, it's a lot of material. So we store it all in these little drawers, and they can go back into the portal. You can see live session materials. We record everything. They've got access to that. We do provide information on specific materials, for example, awareness of pain management, how mindfulness, self-compassion can support us to hold particular health issues and pain. There are a variety of meditations to choose from that can help people to sit and practice and self-regulate and reduce inflammation and stress, etc. And then a reminder of the home practice. So the other side, on the other side is the session on movement, which is week 7, the same kind of session materials, live session materials, and specific practices, for example, on balance in the nervous system with movement, specific movements for people with pain and limited mobility, conversations on movement and pain and illness, how people are coping with that with various guests, meditations and home practice. So there's a real variety of resources, and people can take the time to look at those over the week and just give you a sense of the whole course. This is how it runs. So there it is at the top: awareness, the ability to see clearly what's happening moment to moment so that we can choose wisely and kindly to access whatever it is that we need. And that might be medication or rest. Or the second week is about breathing, a lot about self-regulation, about mind training. There's a lot of looping and negativity when there's pain and illness, and there's often fear and anxiety. So we're offering, enabling people to train the mind to anchor on a specific object like the breath, so as the whole nervous system can begin to calm. There's a session on compassion-based practices, the importance of connection with the self, not just the difficulties that we experience, but the neutral experience of the body and pleasure in the body. So just beginning to broaden awareness to include a more balanced approach to life as well. There's the behavior change tiny habit model that I've spoken about. In the next couple of weeks, these are very supportive practices in terms of nature. There's a consolidation week. It's a lot of material, digest for a week, catch up on resources, rest, and then move into engaging with movement and sleep hygiene and healthy nutrition. And there's the various components that we offer, the weekly live sessions, the home practice, and the buddy groups. Thanks, Graham. Okay, and there's just an example of resources where Vidyamala is talking to somebody with rheumatoid arthritis and limited mobility. So these are just case studies that people can check in. That just gives a sense of not being alone with whatever their people are dealing with. So just to say a little bit about the pilot studies, the methodology used to compile a program is to identify key areas, lead a pilot, learn from the pilot study, make adjustments, and the first course was launched, the first program was launched in 2024. So the pilot studies, there were 3 of them, 26 people from the Breathworks community. The second pilot study, 31 started the program, 25 finished it. They completed the program. The majority were new to mindfulness and knew very little about meditation. All of them lived with chronic pain or supported someone who did. And that was a 10-week course. So we tried different formats. And the final pilot was 25 people. And they were from the GP practices, clinicians, managers, health coaches. And on the basis of feedback from all of those pilots was launched an 11-week program. And you can access the second pilot impact report that was done in 2024. And it's just leave you with some of the feedback from the evaluation. So the people completed 3 sets of questionnaires before the course started, at the completion, and at 3 months follow up. And we used the Hospital Anxiety and Depression Scale, the WHO 5 Wellbeing Index, and the Pain Catastrophizing Scale. Sorry, just there we go. Some other just stats to skim it over. So just reporting reduced anxiety and depression. They're often accompanies illness and chronic pain. And just a high percentage of people reporting lower levels of catastrophic thinking upon course completion. And there's a post-course reduction in anxiety and depression after 3 months, and increases in sense of quality of life, and decreases in pain catastrophizing after post-course and after 3 months. So just I'll just dip into this. Some of the feedback that we've had. They seem small advances, but they're very significant for many, many people. Just noticing about improved sleep, reduction in medication. We don't advise that. We're here to support people with whatever therapeutic approaches they've got. It's an and approach, helping people to look at anything that helps them to support them and their well-being. Encouragement to move as we can incrementally. And what we've learned, I think, most clearly is that what makes the most significant impact for people in terms of well-being and mood is coming together each week and having meaningful conversations with people who share their situations. So this was just some feedback from health professionals, from one of the pilots. It was very, very promising that we were on the right track. That was pitched well, and there was support. We'll be doing some work with particular health centres. We'll be running the course there, and we'll be running it in other health centres, collecting data. Hopefully responding to the call by the government for preventative care. We'll be continuing to provide, make the course accessible online, and there's an app in development as well, which will significantly support the tiny habit model and other aspects of the course, and that's where you can find us. So stop there. We've got 5 minutes to go.
Thank you very much. Unfortunately, we haven't got any questions, I don't know why, in our Q&A. But Graham had one question for Dr. Mullah and one for you, because you're on there. I will start with you, Colette. So his question was, that some patients who are new to observing and noticing their internal experiences can find sitting with their pain, thoughts, feelings really hard initially. And do you have any suggestions on how to reassure these people?
Yeah, it is hard to sit with pain, whether it's mental, emotional, or physical. And we can use that experience in order to provide a bigger container to enable us to allow a very low level of pain to be present. And we can learn not to be drawn into that experience and overwhelmed. So we can use a certain amount of education to help us stay balanced between overwhelm and avoidance, or avoiding with other substances or eating or whatever it is. So that just to learn those skills of training the mind and basic balance skills that enable us to come into a more healthy relation to what's difficult without blocking it or becoming overwhelmed by it.
Thank you, Colette. And one question from me, because in your heels, you mentioned first thing was healthy nutrition. And nowadays we are seeing much more evidence about the gut microbiome and pain. And so
Yeah,
what
we have a whole section on microbiome and education about. We're not telling people what to eat. We're making suggestions and making links to healthy gut that is related to pain and inflammation. And then we're providing people with resources so they can go away in their own time and read up on that and then share with each other. People are sharing apps where they can find out more information about those connection between those two things.
Thank you. And one question for you, Colette, is from John O'Sullivan. He's thanking you both, you and Dr. Mullah. And his question is regarding the BreathWorks program. Are you aware of any free at the point of delivery courses, perhaps commissioned by health services?
Who is that question for?
For you, Colette. Regarding the BreathWorks program, are you aware of any free at the point of delivery courses, perhaps commissioned by health services?
I don't. You know the slide I showed you with the GP, the list of GPs that may be rolling out the program. I think we're working on getting funding to make sure that those courses hopefully can be free at the point of delivery, but we need support to do that, I think.
Okay. Another question for you, Colette, from Gail Postel. What is your selection criteria for your HEALS program?
I'm running a public course at the moment online. I've run about 3 in the last couple of months, and we're welcoming people who have pain. It could be through an injury or through other means, or a chronic illness or long COVID. But if people want to come on because they're interested in how to support and prevent illness, we're really happy for them to come through the program as well. It's preventative as well as supporting people who are already in pain and have got injuries or immobilities.
Thank you very much. Please type your questions in our Q&A. And now questions for Dr. Mullah, if he's there, Dr. Mullah. One from Graham that he wants to know, how often do you find yourself using the more off-label medication approaches? And in your experience, do they provide long-term benefits for patients?
Yeah, I mean, the off-label, obviously, yes, thank you for your question, Graham. And apologies, I overran by a few minutes. I checked on the web. I mean, bear in mind, I'm doing the webinar from India. It's midnight. And yet my whole circadian rhythm is affected. Yeah, so in terms of the use of off-label, we have to contextualize it. So, for example, if you prescribe somebody a medication which is not in conformity with the NICE and MHRA guidance. An example would be, say, for example, if a patient came with neuropathic pain and before trying, let's say, an amitriptyline or a duloxetine or a gabapentin, if I found that I could give them any other medication which is not out of these three, which is part of the NICE guideline. An example would be, let's say, lamotrigine, which is a sodium channel blocker, but it's not first in line. It's not off-label, but if you explain to the patient that it's a little bit away from convention, but seek help of, say, for example, a neurologist, then you can prescribe it. But if you're talking strictly in terms of off-label, for example, cannabis, because I assume your question and a lot of that from the primary care will be around cannabis. So my personal practice is not to use any cannabis, because within the NHS, cannabis is only licensed for a type of pediatric epilepsy called LGL, intractable vomiting from chemotherapy, and certain contracture disorders in multiple sclerosis. Any other use for cannabis, which people are using it galore in pain medicine, is actually off-label. But just to say that that's not my practice, and this is not something I would recommend.
Thank you, Dr. Mullah. Yeah, thank you. One question from me, because you mentioned in your WHO ladder, which is basically American-based, and you say at that level 3B about IV lidocaine and IV ketamine infusion. And what I have heard, not many clinicians, pain consultants, they use it, and not many centers they provide it. So what is your experience? I know you said you provide with lidocaine with 5 milligram per kg over 2 hours period. So I just wanted to know what's the general consensus from the faculty or British Pain Society.
Yeah, thanks for that. So this also is likely to answer a little bit of Graham's question, that IV lidocaine is actually off-label for this condition, if you like, okay? But there's an NIHR study which is going on. Alan Fayaz, a good friend of mine from UCL, he is, I think he's one of the investigators in that study.
Okay.
And UCL is like the closest tertiary setup for Lieutenant Dunstable. So a lot of the patients that they were doing, they're sending it to me because I've got experience in it. So I use it for long COVID and for other type of nausoplastic pain syndrome. I find it incredibly useful for multiple sclerosis and any type of central sensitization pain. Actually, Satish, the problem with lidocaine is quite cheap. The problem around giving IV lidocaine or ketamine or combination infusions, it's the resources and the organizational support. So, for example, I'm able to strategize it in a way that I don't require a separate facility to do it. So if I'm doing my pain injection list, then the recovery staff have kindly agreed to have one bed space booked for an hour to 2 hours for these patients. So the challenge really is for organizationally being able to successfully use it. In terms of evidence, there are proponents of it and there are opponents of it. It has to be, a case has to be made for it. So, I mean, I'm not running a lidocaine spa. Okay, patients can't keep saying, because it's a vasodilating drug, it gives them an immediate sense of euphoria and they feel nice, they feel rejuvenated. And I've got patients who want to come and have it repeatedly. That's not how it works. And in my area, we have certain commissioning constraints, but in certain areas, they might ask you to do an individual funding request form, which is very painstaking. It will just wear people off and they won't do it. So I would say I'm lucky for it.
Thank you. Thank you. Unfortunately, we don't have any more questions in our Q&A. And just thanks from Manfred Koch that he's for both your presentation. And he feels that the major problem is that the knowledge about the complicity of long and post-COVID. That's where it's still, as you said, it's future is still in infancy, and where we might learn and come out with more things to manage that. Yeah. Okay. Now, I've recently come across, which I have to get a book. It's called, it's by a neurologist, and it's called It's All in Your Head. And the stories from the front line of psychosomatic illnesses, and it's called From Susan O'Sullivan. And the thing it says, even if medical tests cannot explain your pain or tiredness or disability, it does not lessen your suffering. The pain of medically unexplained illness is every bit as real as any other. And if anything, is multiplied by the lack of understanding. And I hope, Dr. Koch, that answers your question, that still we are learning, and that doesn't mean that it's going to end your suffering. Thank you. Thank you for everyone for the excellent presentation. And would like to thank you from behalf of the primary and community care SIG on BPS.
Thank you. Thank you for attending. Thank you for
Thank you,
patiently listening.
Sashish. Thank you.
Thank you, guys. Yeah.
Thank you, everyone. Take care.
Thank you.